why don't we kick it off with Joe?
Okay. Hi, everybody. This is Joe Gallo of ASPE, and I'd like to welcome you to the second part or second segment of AS 101, Active Surveillance. As you are probably aware, this is a multi-video section that will be continuously available even after the presentation from today. I'd like to also make sure that you start off by administratively turning your webcams and your microphones off at this point, unless you're part of the presentation, because otherwise it becomes a distraction to those who are trying to pay attention to the presenters. You may include your questions or comments as we go along. You can put them into the chat. Later in the presentation, you may be invited to open your microphones and such to be able to participate. I do want to give you the formal disclaimer. Any information that is expressed today by any of the participants, including the video presentation, are not intended to be recommendations by ASPE or any of the other groups for any medical treatment or course of action. If you find something that's of interest today, please make note and follow that up with your own health providers. We would also like you to, as you're updating your personal information, if you will identify your country of participation just by going up to the three dots on your particular image and include your country or other location information. It's good to see who everybody is participating. Okay, again, questions can be anytime during the presentation. And so then with that, I will then introduce to you Mark Lichty, the chair of ASPE.
Thank you, Joe, and welcome to all of you. I'm Mark Lichty. I'm chair of Active Surveillance Patients International, and this is going to be an exciting webinar. We created, this coalition of organizations created these webinars because we found that there really was not any clear guidance for men that with low and intermediate disease, and so we wanted to fill that gap. And the coalition includes ASPI, Prostate Cancer Research Institute, ANCAN, and Prostate Cancer Canada, and also Howard Walensky with his Active Surveillance newsletter, The Active Surveiller. And if you haven't signed up for Howard's newsletter, I'd really recommend it. He's an old newspaper guy and really knows his craft, let's say. And I want you all that are here to know that the men that have, there's a lot of effort that goes into the creation of these things. And all the men have been through the mill on active surveillance, and they're doing this just because they know how hard it is for you to go through what you're going through. And we want to help you to find your power. We've helped a lot of men avoid overtreatment and over-biopsying, and now actually we're kind of morphing into trying to help men who are overly anxious. There's a lot of overly anxious men that get treated not because they need treatment. They get treated just because they're anxious. And you can, many of us who have created this webinar here have found some peace, believe it or not. You too can find some peace in this process of active surveillance. And so we're in the process of creating future programs. So we hope that you might give us feedback on these, and we'll try to weave your feedback into that. And all of the organizations here today are in need of volunteers. There's not a lot of budget that's involved here. We're doing this because we see a need. And so if you do want to help any of these organizations, we'd love to hear from you. And I should mention we're going to have a question and answer, and Joe already mentioned to put your questions in the chat if you want, but I'll also do the hand raise approach too. So if you go to the bottom of the page and you go to reactions and click on reactions, you'll see there that you can raise your hand and we'll call on you, or we'll try to call on you. With that, I'd like to introduce Phil Siegel from Canada. Phil, you're on.
Thanks very much, Mark. So I'll just repeat some of the things that Mark's just gone over. Like more than a year ago, many of us involved in active surveillance support met to discuss programming for 2022. The idea was to try and avoid program duplication through cooperation amongst the various support groups. We all agreed that we weren't connecting as much as we should with newly diagnosed men or with men in the gray zone, PSAs of 4 to 10, who had not yet been diagnosed. We thought it would be a good idea to develop a series of videos which covered the basics for men and their partners who may be anxious or worried about what was happening to them with no support immediately available. These videos would be a catch-all group of webinars that would answer many of the questions a recently diagnosed man might have, all in one place without having to scour the internet. A working group called the Active Surveillance Coalition was formed to develop a series of programs under the name AS 101, an introduction or basic course in active surveillance. The vision was to have real patients and their partners simulate visits with top experts in the field and cover the essential questions. Howard, it's all yours.
Okay, well, thanks, and welcome everybody from the United States and Canada and Sweden and Ireland and who knows where else. Our efforts have drawn people from 20 plus countries, 24 countries, going from Canada to India and Singapore, Lebanon. We truly are international. But to pick up on Phil's narrative, today ASB is premiering the second segment of AS 101. And by the way, this is pass-fail. Everybody is going to pass though, because you're going to learn new things and basic things. And the idea is just to listen for about 30 minutes. In our first segment, Larry White, a real prostate cancer patient whose PSA was rising, and his wife, Nancy, who's a strong advocate for her husband as well as other men on active surveillance. First segment, they saw Dr. Stephen Spann, who recommended that Larry and his wife, Nancy, see a urologist. And so in this episode 2, we have a series of cliffhangers. So the last we saw Larry and Nancy, they were being invited to see a urologist. Well, they luck out in this series because the urologist they see is Dr. Lawrence Klotz, the father of active surveillance. And Dr. Klotz is having sort of the first patient visit with Larry and Nancy in this video, and they cover the basics. And there will be a subsequent program with Dr. Klotz, and we also will be having Dr. Jonathan Epstein, the Gleason pathology guru from Johns Hopkins, Justin Lawrence, a genetic counselor from the University of Toronto, and we will have others, and eventually they'll all be put together as Active Surveillance 101. At any rate, that's the introduction, and I hope that you learn something, get something out of it. So I'm going to, well, I should say, if you have questions along the way, enter them in the chat. After the program, we'll be opening up the floor to questions about the program, and if we need to, if you're interested, we can take other questions from the floor. And so either your questions will be asked by you, if you prefer, and raise your hand, or they'll be announced for you by one of the moderators. And just remember, as Joe said, we're not here to give you medical advice. But at this point, Bill, maybe you can start the video.
Mr. White, I'm Dr. Klotz. Nice to meet you.
Very nice to meet you.
I see you're here with your better half.
That's right. Nancy has joined me. We're trying to figure out this process together as a family. And she's the better part of this group and has done tremendous amounts of research on prostate cancer, probably more than I have. And, we have some questions that we have written down and so we don't forget. And we also wonder if it would be possible if we could record the session. So once we get home, we can kind of listen to it as we begin to take your advice and everything. Sure.
By all means, and it's good to have a second pair of ears to listen to the story. Let me just ask you a few questions. You're in good health generally?
Generally, I do have high blood pressure that's well controlled. Otherwise I'm pretty healthy.
And how old are you now?
I'm 70 at this time.
And do you have a family history of prostate cancer?
I do. My dad had prostate cancer and probably died secondary to prostate cancer, but I'm not sure about that.
Around what age?
He died at about 74, developed prostate cancer in his late 60s.
Okay. And have you got any symptoms as far as urinating?
No.
All right. And this is really about your elevated PSA. So I gather your PSA was elevated recently. Do you know the value?
Recently, the most recent one was 6, and that's what kind of precipitated this visit. But because my dad had prostate cancer, we've been taking it periodically, and we've watched it kind of go from 2 to on up to 6 over the course of a few years.
Okay. So would you know what it was, say, a year or 2 ago?
Yeah, I don't at this time. I'd have to look at my records and find that out.
Okay. I see you've got some questions. Do you want to start with questions about where you'd like to go with this?
Well, I guess my main concern is my PSA has gone up.
Right.
And perhaps more rapidly than Dr. Span thought was reasonable.
Yes. Okay. Fair enough.
And so the PSA is one issue, but he introduced us to active surveillance. So I guess we're trying to figure out, am I a candidate for active surveillance, but really, do I have prostate cancer? He wanted me to come to you as someone that's going to be able to hopefully help us figure out diagnostically what's going on and what might be the best course of action for my treatment.
So, and I gather from your family doctor that the examination of your prostate was normal.
Correct.
So your major risk factor is your family history and your PSA. The PSA does go up with age normally as the prostate gets bigger, which is kind of a normal male phenomenon. And yours is really borderline for your age. In the 60s, the upper limit of normal is around 4.5. When you reach 70, it goes up to around 6.5. So yours is kind of at the upper limit. And with your positive family history, and particularly with your father actually succumbing to the disease at a relatively young age, you certainly have a kind of moderate risk of prostate cancer. And we can run the numbers on an online nomogram, but my estimate, given those various parameters, is that you have roughly about a 15 to 20% chance of having a significant prostate cancer, and probably another 15 or 20% chance of having a what's called a clinically insignificant or a low-grade prostate cancer. So yes, the first step is to make a diagnosis. The discussion about active surveillance really comes once we know what you have.
Right, right.
And if you have one of the favorable low-grade types, or even one of the kind of borderline intermediate types, active surveillance, definitely an option, but we have to get there first. If you have a high-grade cancer, active surveillance is not a good strategy. You need something done.
Okay.
So the next question is, how do we make the diagnosis? This whole area has shifted considerably just over the last few years. Historically, you would have been subject to what's called a systematic biopsy, which usually means 12 needles poked 12 times from your rectum into your prostate. So this has now changed dramatically. First of all, we usually image the prostate before doing the biopsy. So the next step would be for you to have an MRI of your prostate, and some places, including myself, are now using a new technology called high resolution micro ultrasound.
Okay.
Both of those are very sensitive for picking up significant cancers. So if you're game, we'll put this into gear, we'll see what it shows, and then we'll have a discussion about what to do next. And basically I would say, if your imaging shows, the term is a region of interest, which really means an area that is suspicious for significant prostate cancer. If it shows that, then we proceed to a targeted biopsy where we just put needles into that lesion. So that's the plan. We'll arrange the imaging and we'll take it from there.
Okay. I'm a little bit anxious about the whole thing. I mean, how accurate is the MRI or the ultrasound, and are they diagnostic in and of themselves?
So at the moment, the only way to diagnose prostate cancer with complete certainty is with a biopsy.
Okay.
That may be changing. And that in part because of another test called a PSMA PET scan, which is still not that widely available in most places in North America at the diagnostic stage. It's more available at once a patient has actually been diagnosed and even treated for recurrence. So in 2022, we still 100% rely on the biopsy. And there's two reasons for that, or maybe even more. One is that not everything you see on the MRI turns out to be cancer. And particularly the MRI, and both the MRI and the micro ultrasound are graded from 1 to 5 for the reading of 5, which means very, very suspicious. Around 80% of patients will turn out to have significant cancer. It's still not 100.
Okay.
At a reading of 4, it's a higher proportion, about a third or more don't have prostate cancer as far as we can tell. So you can't simply rely on the image to tell you for sure that there's cancer. The other piece of this is that the pathology itself very much drives the treatment decision beyond just whether or not you have prostate cancer. And without going into too much detail, that is also now graded from 1 to 5. It's called the grade grouping, and they are like night and day. Grade group 1 is so indolent and benign acting, it's not really a cancer the way people think of it. We usually don't treat it. That's the basis for active surveillance. Grade group 5 at the other end of the spectrum is almost always lethal. That's rare. And then there's a whole range in between. So there's a tremendous amount of information from the biopsy that goes beyond just whether or not cancer is present.
Well, on the MRI of the prostate, I've been reading about that, and I was wondering, will a contrast agent be necessary? I read that
Yes.
gadolinium can breach the blood-brain barrier and cause some syndromes.
So the first thing I would say is, first of all, it's a very good question. The second is,
you've been reading about this.
the second, gadolinium is safe. Gadolinium is widely used. Anytime a patient has an MRI, the gadolinium most of the time is administered. It improves the amount of information you get from the MRI substantially. We still use it very routinely. Now, for the average patient having an MRI for diagnosis, in your case, for example, it actually doesn't add all that much. What it does add is very good information about the actual extent and location of the cancer. To what degree is it infiltrating into the capsule, for example? So in a sense, you're not there yet, right? We don't even have a diagnosis. And there's an increasingly people in the field are asking, can we dispense with the gadolinium in patients like you, where we're not so much interested in the precise delineation of the cancer. It's really, is it there or not? Is there something to target? So the reasons to drop the gadolinium are basically related to cost, because it does add some cost, and also to the relatively uncommon risk of side effects. I must say at this point, I'm still kind of agnostic about this. I think it does add something, but it's probably not essential for the majority of patients. It probably does reduce the accuracy of the MRI, the sensitivity to some degree. So if you have a strong preference, we could drop the gadolinium, but my advice at this point is that you would have what's called multi-parametric MRI, of which the gadolinium is one of the three, is necessary for one of the three parameters we use.
Well, that's good information. At what point does the biopsy fit in here? I mean, is it if we have a positive MRI or the ultrasound, then?
Right. Yeah.
Okay.
So first of all, let me just address what we do if your imaging is negative.
Okay.
So the imaging is not 100% accurate, but the metric that we use is called the negative predictive value. In other words, if it's negative, what is the likelihood that you don't have anything significant? And the negative predictive value for both of these imaging modalities is around 85% to 90%. So what that means is if the best estimate of your risk of having something significant is, say, 20% based on the parameters that we talked about, it's just simple arithmetic. A negative imaging study means that your risk drops 85 to 90% from 20 to around 2%. Okay. In a guy your age, or just in general, a 2% risk is not something to take seriously. You know,
Okay.
100% confidence you don't get in medicine.
Right.
That 98% is pretty damn good. So in a case like yours, my strategy would be, if the imaging was negative, not to pursue it any further. Now, and we would probably, we would definitely follow your PSA. If it continues to rise, the question can be revisited, probably another imaging study in 2 or 3 years, that kind of thing. The alternative is to do the biopsy regardless. So that would be the traditional 12-core systematic biopsy, because there's no target. And that would be warranted if you were at higher risk. Let's say your PSA was 20, and particularly if you had other risk factors, you've got the family history. The other risk factor, of course, is race, or African American or Canadian, or if your prostate feels suspicious. So if you had some other risk factors plus a higher PSA that put your risk more in the range of 40 to 50%, then negative imaging is not enough, and you still have to proceed with the systematic biopsies. But increasingly, at least for me, it's really about targeted biopsy. No one wants to have multiple cores if they can avoid it. And the other thing I would say is there's some evidence that the cancers that are missed with imaging are also likely more favorable cancers. They're probably smaller, They are also, the evidence is suggesting biologically less aggressive. So in other words, the downside of missing a small cancer that was, of not diagnosing it because it wasn't seen on the imaging, is probably in the vast majority of cases not very serious, and therefore you can follow the patient and everyone is happy not to have a biopsy.
Yeah.
Okay. So that's one scenario. On the other hand, if your imaging shows a significant cancer, a significant region of interest, not yet a cancer, but a region of interest, and that would be on MRI, what's called PIRADS 4 or 5, a grade 4 or 5 out of 5. Grade 1 and 2 basically is favorable. In other words, it means your likelihood of something is very low. Grade 3 doesn't really move the needle one way or the other. It's completely equivocal. So we're really talking about a PIRADS 4 or 5. Then you would go on to have the targeted biopsy. And whether the rest of your prostate is also assayed really depends on your underlying risk. In my practice, I would say about 80% of patients only get the targeted biopsy nowadays. Mm-hmm. And then we follow the rest. So the next question that, not to preempt you, but the next issue is how the biopsy is done. So this is also, this has also evolved quite recently. So traditionally, this was called a transrectal biopsy. And the appeal of that is the prostate is sitting right adjacent to the rectum. You put the probe in the rectum, the needle goes through the probe, through the rectal tissue right into the prostate. And it's very accessible. It's very easy to anesthetize the area with local freezing. And that's how it's been done for basically 40 years.
And that's what most of my friends have had done, that have had.
Right. So there's a problem though. And the problem is you're taking a needle and you're inserting it from basically a very non-sterile location, which is the rectum, where there's poop, and you're injecting it through that into the prostate, which is normally sterile. And you do it with preventative antibiotics, with an enema to clean out the rectum. But despite best efforts, a small proportion of patients, and depending on which series it is, somewhere between 1% and 4% of patients having that procedure get an infection. And the infection can be quite severe. And they also can have bleeding because the blood supply in that area is very, very robust. And so for those reasons, and I should also add, there is a mortality rate from that infection. It's very low, but it's not zero. And every one of those cases is a catastrophe. It's probably somewhere between 1 in 1,000 to 1 in 10,000. But you consider in the United States, there's about a million biopsies done a year. You're talking about a lot of patients nationwide. Right. So for those reasons, there has been a switch in many people's practice. I am one of them. I've completely switched to what's called transperineal technique. So the ultrasound device still goes up the rectum, but the needle goes through the skin in what's called the perineum, which is the skin just between the scrotum, the back of the scrotum, and the anus. And that is, you sterilize that area. The needle goes in sterilely. There's essentially no risk of infection. There's very, very low rate of bleeding. It's safer. And in my opinion, it's a better way to do it. So I think this is really a shift. It takes a while to change practice, but that is definitely the way people in the field are moving. Now there's, with everything, there's a benefit and a downside. The downside is it's a little harder to get good anesthesia. Patients do seem to feel it a bit more. And also the needle has to travel further to get to the prostate. So you need a little bit of extra equipment to make sure the needle is lined up properly and doesn't get deflected one way or the other. So there's kind of some additional skill sets involved, but really, in my opinion, there's no looking back. It's unequivocally a safer way to do it. And my prediction is that within another 4 or 5 years, no one will still be doing the transrectal strategy. So if you just had your imaging, there's a lesion there, we would, under normal circumstances, plan this transperineal biopsy.
Is the transperineal biopsy more accurate, or can you find cancers maybe that you wouldn't even find in the transrectal? Or
Yeah. So the many people have looked at this. Basically, the diagnosis rate is the same.
Okay.
It's the appeal of it is more the safety than the accuracy.
Okay.
There are parts of the prostate. So you can imagine the prostate sits on top of the rectum. Most prostate cancers, but not all, but about 70% occur in the back part of the prostate, right next to the rectum. So that's very easy to access either way, probably even a little easier with the transrectal approach. But the so-called anterior cancers, the cancers that are at the front part of the prostate, close to the pubic bone, those are more readily evaluated with the transperineal technique. So that part, there are some advantages with respect to location.
Okay.
So I've heard about liquid biopsies too. Is that happening yet? Is it?
So this refers, yeah. So this refers, it's a bit of a misnomer. A biopsy means tissue.
Okay.
Oh yeah.
So but liquid biopsy refers to using molecular genetic tests to identify the presence or absence of cancer. There's a whole slew of them. There's about 5 or 6 that are now commercially available, and they're basically blood or urine tests. And they have a role in trying to stratify patient according to risk. So, I mean, an option for you would be to have one of these tests. If it's very favorable, then you might, particularly if your MRI was negative, that would provide further support to conservative management, not going ahead with the biopsy. They're emerging. I would say as of today, it's still not that common to do one of these tests before moving on to the imaging. But that may change. It's partly related to the cost of the tests. They cost somewhere around $500 to $900. And keep in mind, they're not a diagnosis. What they do is risk stratify. So they would tell you, okay, based on your various parameters, including this molecular genetic test, you have, say, a 5% chance of significant cancer or a 50% chance, and then you still have to make a decision. So you could certainly have one of these tests, and it might, that's another strategy to move forward. If it was very favorable, you might not have to have the imaging. They really are two, at this point, it's kind of 6 of one, half a dozen of the other, whether you go with the imaging first or the assay first. In regions where the imaging is widely available and also where it's not that expensive, because most of the time the imaging and the molecular test are in the same ballpark in terms of cost, around $1,000 plus or minus. There's at the moment, I would say it's somewhat of a preference to go with the imaging, which also tells us about location, size, grade, because the higher the grade of the image, the more likely the cancer is to be higher grade and so on. So my recommendation right now is to go ahead with the imaging.
Well, I mean, I have been smiling during our interview, but it's mainly due to anxiety. So because of my dad's situation, and of course I kind of watched that process go on and such. And my preference, I think, is to take the most definitive approach to diagnosing this. And we've kind of discussed this as well, and you've answered really all of our questions pretty darn well. But I really do want to take the most definitive approach, I think.
Right. So I would say the next step is we'll put the MRI into gear, and we'll see what we come up with. So what I normally do is once I get the MRI report, I'll give you a call, and we can decide whether to go ahead with the biopsy if there is something on your MRI. If there's nothing on your MRI, if it's negative, you may elect to go the route of one of these molecular tests, just to really consolidate the fact that despite your family history and the rise in PSA, that you really have a very low risk of having significant cancer. And those, just to be a little more granular, the molecular test, there's one called the 4K test, the PHI test, the MIPS test. There's a whole series of them. They all, in my opinion, perform around the same, and we can kind of cross that bridge depending on what your MRI shows.
Okay, well, that sounds reasonable, you think?
Okay.
Okay.
All right, so it's been a pleasure talking to you, and we'll get the ball rolling.
Thank you
so much.
Thank you.
Well, what a story that was. And thank you so much, Dr. Klotz. You have showed tremendous courage, because I know when you first got into the active surveillance world, it was not a popular world to be in. And so we admire you and respect your courage in taking a leadership role. All of the participants today were volunteers, no compensation. We have no budget. Larry, Nancy, great job. And behind the scenes, you didn't see Phil Siegel and Howard Walensky, but they've been driving forces in creating this piece. And Alex and Peter, Alex Schultz and Peter Schultz, thank you so much for PCRI's role in editing this and making this happen. Much appreciated to all of you. Thank you. Well, we're back. I hope you all found that informative. I actually took some additional notes. I just wanted to reinforce something that Dr. Klotz said about the transperineal biopsy. I myself, actually, I was diagnosed over 17 years ago, and I haven't had a biopsy for 16 years. And why I chose not to do that was because I was concerned about sepsis, but also I've been fascinated with the microbiome and how important that is in our overall health. And if we have antibiotics, it actually takes months can take months for the microbiome to come back. So the transperineal biopsy is really something that if you feel that you need a biopsy, if your doctor really feels that you need a biopsy, that's something you want to consider. We, ASPI, if you go to our website, did a program on that with a doctor by the name of Popert over in UK. And we're playing a large role in kind of nudging the use of the transperineal biopsy along. I guess maybe I should somebody asked me to handle this first question in the chat. And again, if you want to raise your hand, raise your hand. But the question was about the TURP, if transurethral resection of the prostate. Now, I actually had one of them recently, by the way. I don't know who, Jim, you asked that question. I actually had 2 green laser therapies, which is the same thing, using a laser to go through the urethra and open that up. As you know, what happens is the 2 sides of the prostate grow over as we age, and they start to impinge on the flow of urine, and that's why we have the issues that we have. And so after I had 2 green laser therapies, I said, well, let me try a TURP. The question here is why, if you can use a TURP to clear out the urethra, why can't you just use it for a prostate biopsy? You really can't access the places that you might have to access. Well, plus I think, and now none of us are medical doctors here, but likely you would be doing damage to the urethra as well. So I'm imagining that's why that doesn't happen that way. Howard and Phil, are you seeing other questions in the chat that you want to answer? I'm looking for hands. Did anybody raise their hand too? Howard, you there?
I'm not seeing a lot of questions, but I put in a reminder about the survey because we do cover transperineal versus transrectal in the survey, and we really want the patient voice to be heard. As it happens, the American Urological Association, for the first time in 7 years, is starting a review of their guidelines. And their previous guidelines gave a strong nod to transrectal biopsies and barely mentioned transperineal. And this contrasts with the situation in Europe, where the European Urologic Association last year in January adopted guidelines saying that the transperineal is the preferred approach. There was a major story that came out of Norway where a man died. It became national news because he died from sepsis from a prostate biopsy. And so guys voted with their feet in many places in Europe and also Australia. And the physician organization changed their guidelines. And I was talking to their policy director from the EAU recently. He told me that transrectal is considered medical malpractice in Europe. Far different situation than in the United States. So at any rate, I added the information again about the survey. I can tell you, I've had a peek ahead, and well, actually I shouldn't say anything about it. I can tell you what we found last year was a significant percentage of men who did the survey last year said their next biopsy would be transperineal. And so it was roughly 25%, or wait a minute, 17% of respondents had transperineal. People like you, compared to the national average in the US of 5%. So there, as Mark has indicated, because of patients like us, the medical profession is starting to listen to our views. So I urge you to take the survey, and I'm going to nag on you until you do. So.
And he will. Howard can be a real nag.
That's what I'm
But
saying.
we love him anyway.
Well, thanks.
So I'm going to let this go this way because I don't actually see any hands, or maybe I don't. Well, if you want to unmute, if you have a question and want to unmute, we'll try this. Just unmute yourself and ask your question. This is there's a lot of knowledge, not just amongst us, but I think too amongst the viewers. So this is an opportunity for you to ask questions.
Hello.
Yeah.
Hi, this is Susan. My husband couldn't make it today.
Yeah. Welcome, Susan. Go ahead.
What if you like your urologist and he's doing all the things that was reviewed today, but he doesn't do the perineal? But that's the kind of biopsy you want. What do you do in that situation? How do you approach your urologist?
Yes, Susan, if I can, how about a little bit of background? Where do you live, and where are you seeing this doctor?
I'm in
in
Illinois,
a private. Oh, well, I'm in Illinois too, but we're in Illinois.
in Naperville.
Oh, well, there's plenty of choices in the Chicago area. I can be specific about that, of doctors who do transperineal. I don't really want to do an ad for any
Right.
particular doctor, but I can mention, for example, I see Dr. Brian Helfand up in Glenview, and he does transperineal. They do transperineal at Northwestern University.
Okay.
They do transperineal at the University of Chicago. Is it worth it to switch doctors just to get transperineal? Well, that's between you, your husband, and your father confessor. You know, is it worth it? Well, the one thing's for sure, if your husband has transperineal, he's going to avoid the risk of sepsis. And sepsis is not something to be messed around with. It doesn't happen that often, but it does happen. And there have been estimates that by Norwegian researcher that 2,000 American men a year die from sepsis caused by prostate biopsies. There's controversy with that. So, you know, if you're happy with your doctor, I mean, one scenario would be to kind of get a second opinion from another doctor and ask for a transperineal. So that, you know, that's my suggestion. You know, you're lucky in Illinois. There's huge areas in the United States and in Canada where transperineal is not readily available. And like Larry and Nancy, who were featured in the video, they did their homework, and they live in Albuquerque, New Mexico, and they drove 1,200 miles up to the Mayo Clinic in Rochester, Minnesota, so that Larry could get a transperineal biopsy.
I see.
So, you know, Susan, it's really up to you and your husband. I'm not doing a bad rap on your doctor. I mean, he's certainly practicing within the guidelines as they exist in the United States, but you know, what he's doing is considered medical malpractice in Europe.
Okay.
I'm not trying to scare you, but how long is your husband? Well, is your husband's on active surveillance, or where is he at?
No, he's on rising, he has a rising PSA, not rising a lot. And he did have the MRI with the contrast material, and they did notice some, you know, spots there. I think it was 3 and 4 on that
Oh, wait a minute. So he had
radiology scale from the MRI.
PIRADS.
Yeah,
PIRADS.
yeah, yeah.
Well, 3 is considered, you know, not necessarily anything. 4, you want to be more watchful of. And he's had no biopsy at this point.
No, he's had biopsy like 25 years ago twice because of a rising PSA, but nothing was found. And then he's getting PSAs every 3 months, and he had the 4K test, and this last PSA actually went down very, very, very slightly. It sort of
Well, what is his PSA?
Well, he's on Proscar, so you know, I think it was around 5 something, but
Yeah, well, Proscar cuts PSA levels like in half.
right.
So,
Well, Howard, if I could add to one of the things,
Yeah.
I'm sorry, I didn't mean to interrupt, Howard, but I didn't want to lose this thought. One of the important things is the PSA density. We should all be talking not about PSA, but about PSA density, because the PSA density takes into consideration of the size of the prostate. So a prostate that is twice as large as the average, which is 25 to 30 grams, would emit twice as much PSA. So you always have to know what the density is, and you just put the PSA over the size of the prostate, and I'm sure he has that data.
Yes.
As long as it's under 0.15. I don't even know whether the doctor, if it's under 0.15, I don't even know whether the doctor would recommend that he have any further biopsies. But if you don't, do you know what his density is, PSA density is?
I don't have it at this point. I don't have the records with me, but that's a good point. And we're supposed to see the urologist in the next month and then talk about whether he should have a biopsy or not. Because he's getting PSAs every 3 months now.
Well, Susan, how old is your husband?
He'll be 84.
I mean,
Oh, boy.
there are some recommendations that you stop with the PSAs at age 79. But this is again between you and your husband and your doctor. But there, I mean, if he's 84, he probably, odds are, doesn't have to worry about any of this.
Mm-hmm.
You're being cautious. Question is should you be that cautious? I mean, having PSAs every 3 months is very frequent. And it's true that some doctors consider a PSA of 10, well, they look at this gray zone between 4 and 10. But, I'm a writer based here in Chicago. I was the medical reporter at the Sun-Times for 25 years. That doesn't make me a doctor, but I am a patient. And thing is I was interviewing a doctor at the University of Michigan. He says patients are very literal with these numbers. And a lot of guys really start worrying when it's 10. And this guy at Michigan says, as a doctor, he really doesn't worry about it till it reaches about 15. And there's just one other point that I'd like to make. And before we get off, I'll dig up the article I wrote on this. You need to find out what laboratory technique is being used to measure the PSA. I know a guy in Ann Arbor who was around 10, and his lab switched over at the University of Michigan to the World Health Organization standard, the WHO standard. Suddenly his PSA dropped to 6. It dropped like 25%. And so some of these PSAs are being overstated by the labs. I'll dig out and post the article. But the point in talking to you, Susan, well, first of all, you're to be commended, just like Nancy is, and my wife for that matter. Not a lot of women get involved with this. And so your husband's lucky to have you looking out for him. But what we talked about here, I think, is instructive for other people in the audience as well.
I think that too, Howard, and I'm glad we're treating this thoroughly. I did want to mention about continuing the PSA, Susan, that merely knowing that every 3 months he's going to have to do this produces anxiety. And to tell you the truth, it shouldn't even be on his mind. I mean, I'm 73, and I'm not even sure I'm going to do any PSA. I probably will do PSAs annually, but I'm not even thinking. I'm not even personally thinking about it or worrying about it. After 17 years on active surveillance, I don't even worry about prostate cancer. And so the United States Preventive Services Task Force, they require men from the age of 55 to 70 that the doctor, he doesn't have to insist on a PSA, but he has to ask the patient whether they want a PSA. Now, after the age of 70, the doctor doesn't even have to ask me if I want a PSA or not. They're after 70, they're pretty much done with it because, I'm not going to die of prostate cancer. I'm going to die of something else. And that's the way the medical system looks at it as well.
Well, we had a situation in our family where his brother-in-law did not get PSAs in his late 70s, early 80s, and he did end up being diagnosed with prostate cancer, and it was in a late stage, and he did die from it. in his
Well,
mid
that's,
80s.
that's.
So
that's a-
that kind of, you
Sure.
know, that maybe
got
we
it.
ought to just keep checking because,
Yeah,
you know,
I can understand that. And that's an important story for us to hear as well. And so there was a man that was diagnosed late, and that's not uncommon. I mean, we had 35,000 men die of prostate cancer last year. And so that story is a strong testament for late stage testing and even late stage biopsies. That's an unusual story. We don't usually hear that story, but thank you for sharing that. I appreciate it.
and
You know,
his
Mark-
urologist did suggest maybe every 6 months. And then we talked with our family doctor and he said, well, if you're a little bit nervous, just, you know, get it after 3 months. So we're going to have a conference with our urologist in
Perfect.
December about everything. So
Okay, we should probably move on to.
Yeah, we should. I was
Okay,
thinking that. Does anybody else want to unmute?
Yeah, Mark, try Jim Zhang has got a question.
Hi. First, I will thank to this program, thank to the organizer, and thanks.
You're welcome. Appreciate it.
Yeah. My name is Jim. So I have a question. Can I release the medical information to discuss? Is okay?
Oh, you want to release your medical information to
Yeah, my
discuss
personal.
here right now?
Well, You
Well,
can't violate HIPAA with us. We're not doctors. But you should be cautious with your personal information. We wouldn't aim to share it, but you are going to be sharing it.
Well,
So-
if you want, we cannot render medical advice.
Oh
but
yeah, because I think it's relate. I talk about the active surveillance, right? Because I watched before I watched the video, right? So I know that certain select people for active surveillance. But my condition is like I'm a Grayson
Oh my.
Grayson 7.
But it's a
Grayson
3
score
plus
7.
4.
It's 3 plus 4,
Okay.
and the 4 is 10% of the percentage.
What is the percentage?
10%.
It's pretty low.
Yeah, so when doctors talking about like treatment for one operation, one radiation, but I now have the third solution. I watched the video like Dr. Shu on the program, right, on YouTube, Dr. Shu.
Mhm.
So he's talking about the Gleason's 3 plus 4, and the 4 is 5% is absolutely you get active surveillance, but
Wait a minute.
from 10% to 20% maybe is a candidate for the selective candidate for the active surveillance. So my question is like Midas condition can be active surveillance.
Well, Jim, first, let me respond to your first question. Could you share your data? I feel like we've got some other hands raised, but I do want to try to address your specific question now. Are you a candidate for active surveillance? I'll say this, and the others on this call can chime in, but that feels, yes, there are people with your condition, your situation that are on active surveillance. That is true. Whether you should be on active surveillance, that sounds a little bit like medical advice, and we don't do that.
Can I ask Jim a question? Because I didn't quite hear
Okay.
that. Are you saying, Mark, that, well, let me ask Jim directly. Jim, where do you live?
I live in Canada, Vancouver, yes.
Oh, in Vancouver. Well, I know we have some other people on the line from Canada, including Phil. I mean, you could get a second opinion from Dr. Klotz in Toronto. You could just do a video, visit with him and whether your situation warrants active surveillance or not. And again, we're not here to sell his services, but I think we have somebody who from British Columbia who's online who's done that. And I wonder if he might speak up. And
Do
Joe?
you see my situation?
Well, maybe similar. Joe Mingrone, are you there?
Yeah, hi, can you hear me?
Yeah,
Yeah, we can hear you,
Okay.
Joe. Go ahead. Sure.
Well, I found it a challenge to find doctors in British Columbia. Well, I'm Victoria, but I've also looked in Vancouver for active surveillance friendly physicians, urologists. But recently I did find, I mean, I don't know if I can give a name of one, but he seems to be on board with my decision to go with
well,
active
maybe you
surveillance.
can help Jim out one-on-one.
Well, it's Dr. Black, Dr. Peter Black. He recently took over my case, and he's completely on board with me on active surveillance, and I was getting only resistance from others. So
Hey, Joe, are you a Gleason 3+4?
yeah, I'm pretty much the same as him, 3+4, 5%, for potentially, also I had trouble with, challenges in Victoria might be getting second opinions and things of that nature because of the resources. We have a real health crisis in BC, and my doctor was my original urologist was resistant for me getting second opinions, and I went to Epstein and got a biopsy. My pathology read, and it was quite different than the local UBC, University of British Columbia based doctor, although Dr. Black is a member of that system. And there seems to be like he's got his favorites in pathology, because he agreed with me that my Epstein pathology report made more sense than the one done by his own university. So but I found that there's some, I've been kind of talking about the challenges of because I'm a US citizen. I've been living in British Columbia for 3 years, and some of the challenges, like you can't get, I don't know anybody in BC who's gotten a trans perineal biopsy. I mean, they don't even offer it. And and BC is a big province, so if you have to go out of province, that's a lot of travel, and I think there's some costs associated with going out of province. So I mean, there are differences than maybe you have in Chicago, Howard, or some where you have a lot of resources. So is there anything else you want to know about my experience? I don't want to babble on for
I think it should be instructive for Jim, since you have, you're in the same location with the same restraints. And so, Jim, you got the ball and you should carry it. And maybe Mark, you could take on Ray Brown's question.
I will take on Ray's question. Ray,
Thank you.
I would suggest that you ask, Ray's asking, has a fairly favorable MRIs, and he's scheduled for a biopsy next week, but I would ask my doctor to justify why you need a biopsy. I don't understand why you need one, and he needs to step up to the plate and justify that. With a PIRAD 1, I mean, I had a PIRAD 3 and they wanted to do a biopsy, and I just said, I'm not doing one of those. And again, the thing that I really want to emphasize to all of you is that who the best person is to make these decisions about your body? It's you. You are not contaminated by fear of litigation. You are not contaminated by financial issues. You're clean. You got nothing else driving you but your health. And so, when I've refused biopsies, I just say, no, I'm not going to do that. And what can they do? They can't do anything. I mean, it's your body. I want to move on here because we have some
Well,
other.
Phil had something.
Oh, go ahead, Phil.
Yeah, no, I just wanted to put Ray's question in context. It's not a question of avoiding a biopsy. I mean, what he's basically saying is that he's had a number of MRI. He has a very low Gleason 6 with only one core, and he's had biopsies which I assume were negative biopsies because they couldn't find anything else. So he's saying, given the repeated MRIs that don't show anything, but he does have a rising PSA, so he's concerned. Well, I mean, one of the other things that Ray could look into would be a discussion with his urologist about some of the liquid biomarkers, which avoid the physical biopsy, but at least would give him a score in terms, or liquid or the urine or the actual physical biopsy, physical test where they test the core, that the existing core, and at least he'll get a score, a probability score on the core that was sampled previously.
Oh, by the way, somebody asked what the PIRAD score is. So that's an MRI score, prostate imaging, radiation, and
Diagnostic, maybe.
diagnostic. Yeah, the D is, thank you, Phil. The D is diagnostic, and the range is 1 to 5. 3 is one is not, don't worry about it. 2 is almost don't worry about it either. 3 is ambiguous. And that's what I had. And that's when they wanted to do a biopsy, and I didn't want a biopsy. 4 and 5, you might get a little bit concerned about, but indeed, I've seen people that have had 4s and they do it again, and then they'll have a 2 or something. So the MRI is actually not as fine-tuned a tool as we might first believe. And in fact, by the way, I've had a micro ultrasound that Klotz had mentioned, and that's what he uses now. And the studies have indicated the micro ultrasound is as accurate as the MRI. Anyway, we got raised hands. Ken, did we hear from Ken? You want to unmute yourself?
Yeah, okay. Can you hear me?
Yeah.
Okay. My situation is that prostate cancer runs in my family. And knowing that, I've had my PSA tested for over 20 years.
When did you start, Ken? How old were you when you started?
When I started testing for PSA, I was around 45.
Okay.
I'm 68 now. My PSA over all of the tests I've had has never exceeded 4. I had a biopsy around 5 years ago, came back with either 2 or 3 cores slightly positive. The second biopsy I had a year later, 2018, 1 or 2 cores came back slightly positive. My Gleason was 6. I had another biopsy at the urging of my urologist back in 2020, and it came back completely clear. I had an MRI last year, came back completely clear also. Visited with my urologist last month. He did a DRE, and it was smooth, and he said that my prostate appears to be moderate size. He says that he personally wouldn't feel comfortable if I went more than 2 years without another biopsy. But I'm thinking, based on my personal situation, do I even need an additional biopsy given what I've shared with you?
Well, and again, that's up to your urologist. But what I've seen with the biopsy over the last 10 years is Johns Hopkins, for example, 10 years ago was doing biopsies every year, just routinely doing them. Now, today, I think Dr. Klotz is doing them every 5 years for people that are Gleason 6s. So there's an evolving caution with biopsies. And I would, again, suggest you get your doctor to justify why you need one. I don't see any justification about why you need one.
Well, and I do agree with you on that. But when I asked him that question point blank, he said that he personally did not feel comfortable going more than 2 years without one.
Well, he may be one that is not 100% in on active surveillance, like Klotz. Klotz is 100% in on active surveillance. That's his thing. And there's a lot out there now that are 100% in. Maybe you need to find another urologist.
Well, I was thinking that, so I asked him point blank, do I have your low-grade cancer? He said, yes. I'm kind of of the opinion that I shouldn't, but but I also, that's what I'm paying him for his advice. So I'm like stuck in the middle here. I want to listen to his opinion, but my common sense is telling me that maybe it's not necessary for me personally.
And
Our common sense can be a good guide sometimes. Go ahead, Howard.
Yeah, Ken, where are you based?
I'm in Dayton, Ohio.
In Dayton. And the doctor that you see, is he or she in a private practice or a university practice?
They're in a group at a local hospital.
I see. Let's put it this way. This isn't me talking, but I'm quoting somebody from the music group. They're not singers, they're involved with prostate cancer from Michigan. Michigan has the highest participation in active surveillance of anywhere in the United States. They're up in the 90% category. And according to one of my friends, one of the doctors at music, is that the private practitioners are 10 years behind the academic practitioners in his point of view. I don't think that would be 100% true, but you're in Dayton, so you're not far, I don't think, from Cleveland or Columbus. You might consider going to the Cleveland Clinic. Some of the best active surveillance doctors are there. I don't know that he's currently in town. He may be on a sabbatical. Dr. Eric Klein, he's based at Cleveland Clinic, and he is, one of the best in the field. There are others there, and you can contact me. I could give you. I just don't have it right at my fingertips. I could give you the contact for somebody else in Cleveland. You could go to Ann Arbor for that matter. There's tons of good resources there, or Detroit. But I think probably a second opinion would be in order for you. I'm not meaning to diss your doctor, but I think you might get clarity if you maybe you did a video call with somebody in Ann Arbor or in a Cleveland Clinic. What do you think?
That's kind of what I was thinking. I was thinking that a second opinion would probably make a lot of sense in my case.
It'll give you clarity. I'm going to put my email in there. And, if you or anyone wants to contact me, you can feel free. But I could give you the names of people in Ann Arbor, Detroit, and Cleveland. And so you could set up a meeting with anybody anywhere if you wanted. How old are you?
68.
So you're on Medicare.
Yes.
So you should be able to get, like a telehealth visit, for example, and get a second opinion. They'll look over your data and they can give you a recommendation. And then then you have to make choices. If it's concordant with what your own doctor is saying, then fine. If it's not, that's when you really have to make choices. So,
well, and two, Howard, if Ken seeks a second opinion, I might want to ask him, like, how many patients or what percentage of his patients are on active surveillance. Now, you just heard us say in Sweden it's 90%. Well, the average in the United States is 60%. So if he's not pretty close to 60% on active surveillance, or the second opinion that you seek isn't close to 60% or better, maybe you haven't even found the right second opinion. So that's something that you might want to weigh as well. I hope that was helpful. Do we
Yeah.
have anybody else that wants to chime in here? Just to unmute yourself. if
Ken
you-
Cohn.
Well, we just did Ken. Now we're going to do Bruno.
So you got Bruno.
Bruno, you can unmute yourself.
You guys hear me?
Yeah.
Yeah.
Okay. Well, first of all, thank you for everyone here because it's very good resources around. So I really, really appreciate the effort
You're welcome.
and time that you guys putting into it. So I mean, that really helped me. I'm going to give you a quick, brief story of of my situation here. I'm 57, and I had my physical. Like I do every year, my physical, my PSA went from 2.0 to 3.8. And so the doctor said, well, I should probably do a biopsy. So I went to see a doctor. He referred me to a Dr. Kumar in Detroit, in Rochester, actually, is where I live. Did a biopsy, get the results a few weeks later. I go see Dr. Kumar again. And basically, he's telling me that, yeah, well, you have a 4 core affected. If you want any kids, I said no. Then you should have that removed, the prostate removed. And I feel like I felt very bad for the. Yes, go ahead.
Yeah, Bruno, did the doctor precede the biopsy with an MRI?
No.
Well,
so that's where the story becomes better. So when I went to get my results from Dr. Kumar, he's looking at my number. Yeah, you have 4 core. You have a Gleason score of 3+3 and 4 core. And he asked me the question that if I want to have kids. I said, no, I'm done with it. I said, well, you should probably have that removed. Then another doctor.
Let me stop you right there.
Yeah.
All right. So you have 4 cores, Gleason 6, right?
Yeah, 3+3. I'm not sure exactly what that means.
3+3. Well, okay. Your slides from your biopsy were sent to a pathology lab, and there's a Dr. Gleason years ago did some drawings of what cancer looked like at different levels, and so the pathologists determine, are you predominantly 3+3, which is considered the lowest risk, also known as Gleason 6, or are you 3+4, or are you 4+3? And then, then that goes back to your urologist who makes a recommendation. But let me tell you, first of all, with this doctor in Rochester, these days, the more typical thing is to get an MRI first, to get the score, to determine whether you need a biopsy. Doctors shouldn't be, rushing you in like that.
No.
I don't know if you've subsequently had a MRI.
No. So here's the rest of my story. So the day he gave me my result, another doctor walked in, and my Dr. Kumar said, "Here, talk to that doctor." And his name is Kevin Kingsberg. Kingsberg?
Oh, Ginsberg. I know. Yeah, that's who I was.
Yeah.
Yeah, I know Kevin. He's part of the music group in Michigan.
Yes. So listen to that one. He waited for Dr. Kumar to leave the room. He closed the door and he told me, well, you have a good score. I consider that you do active surveillance. But before you do this, you need to do an MRI. So he scheduled me for an MRI, which I'm going to do in a couple of weeks from now, because I need to wait 6 weeks after the biopsy. But he actually told me to see him after the MRI results, and we'll make a decision from there. In the meantime, I sent my slide to Dr. Epstein for a second opinion.
To Dr. who?
Epstein.
Oh, Epstein. Okay.
Yes. Yeah, Epstein. Yeah. So Dr. Kevin Kingsberg sent the slide to Epstein for a second opinion. They said that's a good thing to do. Have a second opinion. And so I'm waiting for the second result. But and also I'm going to see another doctor for a second opinion, to be honest with you. And I'm scheduled to go to Ann Arbor.
Yeah, I would go.
Dr. Todd Morgan.
Yeah,
I got a visit.
He's
Well,
another one of the good guys.
yeah, it sounds
Okay.
like that is such an odd story that the doctor would actually counter the other doctor's advice. But
Yeah, that
yeah, I
makes me
would
feel very
I'd stick with
uncomfortable.
that. I'd stick with that guy, the active surveillance guy. We, if you're okay, Bruno, we just have one more question here, and then I think
Yes.
Steve, if you want to unmute yourself, you're here. Yeah, we've spoken before. So, what's on your mind, Steve?
Just one question here to each of you. Thank you very, very much. Through your efforts to address Ken's angst and others that may not be speaking about whether or not to leave their treating physician and seek a second opinion, I say that all the lectures, aside from ASPE and NCAN and Howard's incredible newsletter and similar efforts on all these three factors, to educate me. There are other forums, including 3 universities and one being out of Canada, on an annual basis, that when the presenter presents, they almost to a presenter will say, seek a second opinion. A second opinion is not an affront to that lecturer or the doctor. So when I listen to the comments, I get the feeling that the problem is truly ours. If we've got these forums to educate ourselves and we ask legitimate questions and we hear the answer, then the decision-making falls back on our shoulders, and a second opinion or a third opinion or 6 opinions should be, as a consumer, the only choice we make, because the decision is ours. And I guess why I'm wordy and so angry is as a consumer, we feel not empowered to make that decision, when in point of fact, it is ours. So
Yes.
thank you to each one of you.
Thank you.
Yeah, Steve,
Thank you,
I
Steve.
think
Coming from you, those are powerful words. I mean, we always say that, but the fact that we're hearing it from you is very powerful.
Let me add something on Steve. In 2010, I was diagnosed with a single core of Gleason 6. And it was less than a millimeter. It was like nothing. And yet a doctor here in Chicago, and by the way, his initials are RP, as if radical prostatectomy. Dr. RP says, I have good news and I have bad news. The bad news is you have cancer, and he gave no clarification of that. The good news is I have an opening in my operating room next Tuesday and I can cure you. And I said, well, what about active surveillance? He said, sir, I don't support that modality. So that was 12 years ago. So I got a second opinion at the University of Chicago, where they said that I was the poster child for active surveillance. And that's what pissed me off about the whole thing, is how close guys like me, well, I mean, back then, only 6% of us went on active surveillance. It's now 60%. So, too many guys, so 40% still are having treatment for something that doesn't need to be treated. And that's why we do what we do. So there was one last question, Mark. Somebody was asking the difference between Gleason 3+4 and 4+3. Do you
can
want to
take it. Yeah, go ahead.
Well, I mentioned Dr. Gleason, Donald Gleason from the VA in Minneapolis. He started all this scoring stuff, and Dr. Epstein has helped modify it. I mean, because a lot of guys get scared. They're told they have Gleason 6, when that's actually the basement. That's where you have the least to worry about. But it sounds like you're halfway to the funeral. But the next level up is 3+4 and then 4+3. Well, 3+4 means there's more of a predominance of Gleason 6, but there's a bit of Gleason 4. And then that switches with 4+3. But there's a huge difference in these patients with, who have 3+4 versus 4+3. There's a much greater risk of serious cancer with 4+3. So, I mean, I mean, that's pretty much how I define it. I don't know if Mark or Phil or anybody else wants to add to that.
I just put some stuff in the chat for him.
Okay.
Thank you, Phil.
So do we have any other questions or?
Well, it's about time to end this anyway, and we should try to end on time unless there's an urgent question. Yeah, please look at, well, all of our information, all of our websites, all of the coalition organizations here have tremendous, very good information. Please join us on November 17th. And if, you know, all of these organizations are really shoestring organizations. We need volunteers. We all do, not just ASPI, but all the organizations here need volunteers. So if this experience here was meaningful for you, we'd love to have you join us. So we'll see. We hope you'll do the survey, and we hope to see you on November 17th.